So hello and welcome to the next round of Zanat's coffee tutorials in oral and maxillofacial surgery with me. And the topic this time is mucormycosis. Now mucormycosis basically is going to be caused by by phycomycetes, which is a class of bread molds basically, or a type of fungi, which belongs to one family, that is mucorales. And if you look back into the literature that how mucormycosis has been affecting people, you will realize that mucormycosis has usually been associated with diabetics or immunocompromised people. So now when you see the association of mucormycosis with a disease like COVID-19, especially this Delta variant, it's not very new to understand that, again, because there are things which are being given to treat this disease which are causing immune suppression. So given all these the paraphernalia caused of the disease, as well as the drugs being used and the general condition of the patient, I think it is very common to expect that immunocompromised individuals of this sort can develop opportunistic infections, and this is one of the opportunistic infections which we are finding very commonly affecting the post-COVID patients. So first you get out of the trauma of suffering through COVID, and after that you have another situation wherein you have acquired a deadly disease like mucormycosis. And when you talk about what areas of the body it is infecting, of course it is infecting the craniofacial region. It is infecting the paranasal sinuses, the nasal cavity. Also the lungs are getting affected by it. The gastrointestinal tract can get affected by it. There are cases wherein it is affecting the skin of the patient. So to my specialty, I will just focused on my specialty, that is rhino-maxillary mucormycosis, with certain cases wherein we've had extensions into the orbit or into the skull base. So I'm going to talk about craniofacial region and basically rhino-orbitomaxillary mucormycosis. So as I said, it's a opportunistic infection, and it has been seen usually in immunocompromised individuals. And how is it affecting these patients? So what are the different proposed mechanisms in which this disease is spreading? So a lot of theories have come up over the last couple of months, as a lot of people in the fraternity of maxillofacial surgery, ENT, ophthalmology, and neurosurgery. So all these practitioners have been involved in managing mucormycosis. So everybody comes up with different hypotheses depending on their experience and observations. But I think it's all in the history, where you get all patients who are coming to us are not those who have taken steroids. Many of them were not even hospitalized. Many of them not known diabetics, but they did turn with values of they did turn up with the high blood glucose values. Or how is immunity related to all this? If you look at the blood picture of these patients, and if you look at the previous literature, you will find that every standard textbook says that the three important things responsible for mucormycosis have been high blood sugar levels, preferably in acidic or acidotic environment, and a reduction of the capability of the white blood cells to phagocytose the fungus. Now, you, me, everybody is actually inhaling these fungal spores all the time when we are living our normal lives. But these fungi do not have the potential to grow and destroy our organs easily. That's because of the defense mechanism of the body. In our body, we have the white blood cells, that's the neutrophils, as well as the lymphocytes. And if you see that in patients who get affected by COVID, you will find that there's a huge increase in the ratio of the neutrophils and the lymphocytes. Now this ratio normally is that you have roughly, I would say roughly 60% neutrophils and approximately 30% lymphocytes in a regular blood picture. There's a range, of course. It's roughly 60 to 75% and 20 to 45% of lymphocytes. So, but in COVID-19 infection, what we have seen in most of the patients is that the neutrophils go very high. And neutrophilia ideally is a bacterial infection indicator, but in COVID-19 you're seeing that the neutrophils are going very high and the lymphocytes are getting reduced. So the ratio between the neutrophils and lymphocytes is deranged. I would say, people will come to you with like neutrophils of the order of 85%, 90%, and the lymphocytes would be reduced to close to about 6%, 10%. If you look into this disease pattern, the immunity is going very low. And when I say that the patients have high neutrophils, it's not necessary that their absolute neutrophil count is that. It could be that there's a shift to the left. There are immature neutrophils which could be showing up in the blood picture. There could be neutrophils which are not competent to phagocytose the fungus which are showing up into the blood picture. Because if you go to the classic texts of mucormycosis, you will find that they clearly mention that neutropenia is a significant thing to have mucormycosis infection, because normally this fungus is supposed to be phagocytosed, but it's not happening despite the high neutrophil count that we are seeing in these patients. So what is it that is actually causing mucormycosis in patients who relatively were just fine before the COVID infection? Well, there are three important things which are still happening. You are giving your patients steroids, you are giving your patients, higher IL-6 inhibitors and all. So, of course, you cannot rule out the fact that these drugs are affecting the immunity very strongly. That's the purpose of giving these drugs in this infection, because you're trying to curb the patient's, cytokine storm on the 8th or the 10th day. So, that cytokine storm is basically an immune response. You are trying to curb that by giving these drugs. And the next thing, that blood sugar levels are going exorbitantly high for people who have maintained regular blood sugar levels within the normal range of a fasting blood glucose less than 100 are shown to have blood glucose levels of the order of 400 and odd. So when these kind of glucose levels increases, what happens with this kind of glucose level increase? What happens is that these products of glucose have something which is known as the advanced glycosylated end products. And these advanced glycosylated end products are the ones which are known to destroy the patient's immunity by affecting things like chemotaxis, by affecting things like the function of interleukins and the functions of this transforming growth factor and the tumor necrosis factor. And I say chemotaxis means the capability of the white blood cells to be taken towards the site of infection is being reduced. So no matter what is your blood cell count or your differential leukocyte count, the fact of the matter is that all this process is being suppressed by things like advanced glycosylated end products. And therefore there is one constant finding that I am finding in most of my patients is that these patients have had the unfortunate incidence of an increase in the blood glucose levels during this phase. Even if the patient has not had diabetes ever, these patients have not had they've not had steroids. Still some of these patients are showing high blood glucose levels. Why is it so? Because if you go back to the New England Journal of Medicine, there's a letter to the editor written by a reputed authority who says that there is something which is known as the new onset diabetes in COVID-19. It is postulated that the coronavirus is also got effects not only in the, it's got cytotoxic effects in different parts of the body, including the islets of Langerhans in the pancreas. Now these islets of Langerhans are the ones which are having these beta cells which are making your insulin. So that is the reason why, despite these patients not having had to go to the hospital, not having any steroids, I have patients who have had high diabetes, high sugar levels, despite having none of these. And how do you explain the presence of mucormycosis in these? Second, if you say that the acidotic environment which is being forming in the patients of diabetic ketoacidosis, well, all these patients have not gone into ketoacidosis. Although the classic theory says that mucormycosis grows up in an acidic environment. It grows up also in an iron-rich environment. So you will find all these patients have got high serum ferritin levels. Now, serum ferritin is an important marker of inflammation in the body. But wherever you have high iron, wherever you have advanced glycosylated end product, you are getting this infection. The chemotaxis and the other white blood cell related things are getting reduced, and that's how this fungal infection is growing. And where is it happening? As I said, now the route of entry of most of this fungus in regular individuals is inhalation. So you're inhaling these spores. And what happens when you inhale, there's something which is known as the paranasal sinuses, means the sinuses which are around the nose, paranasal. So there are four different sinuses: the frontal sinus, the ethmoid sinus, the sphenoid sinus, and the maxillary sinus. This is the maxillary sinus here on both the sides. So the nose, the nasal cavity has connections into these. So you have the maxillary sinus, you have behind the nasal bridge is here inside this area of the skull base is the ethmoid sinus. Right behind it is the sphenoid sinus inside the sphenoid bone, and you have the frontal sinus right up here. So all these four sinuses can get affected, but more so what we are seeing is the rhinomaxillary mucormycosis, and I'm going to talk about this region more because this is what comes to me very regularly. So we have these nasal, the nasal cavity. This is the lateral nasal wall inside here, and on the opposite side as well. Now this lateral nasal wall has got the openings from all these paranasal sinuses. So if there is anything going into the nose, it has the potential route already established to reach different areas. Now when this happens, the kind of destruction it is causing is kind of irreparable. So when we open up these patients, so there's no structural integrity which is left in this kind of bone, and therefore the worst thing that we are having to see is that this entire region we have had to remove in many of the patients. This is the debilitation which this disease is causing. This kind of problems are very rare to find and happens only in ablative surgery related to tumors. Usually when you have infections inside the on the face and all, usually infections can be controlled with antibiotics. But what is happening here? Here, just the use of medicines is not helping. The most important drug that probably is there on everybody's tongue nowadays is amphotericin. This amphotericin B again is an expensive drug. Well, but not all forms of this drug are expensive. The regular amphotericin B, that is the conventional deoxycholate amphotericin B, you'll get it for roughly around 300 rupees, 50 milligrams. And the dosage of that drug is roughly 1 to 1.5 milligrams per kg body weight. So if you're like 60 kgs of weight, you can get approximately in a day up to maybe around 90 milligrams of amphotericin. But what happens with the regular amphotericin is that many people develop problems in the kidneys, and it's not that everybody who gets that regular drug will have problems in the kidneys. Amphotericin deoxycholate variant is a cheaper variant, and if you get it, you keep a check on your renal function, because what happens is that when you have a high sugar level, you have amphotericin going into your body, you have insulin problems. So glucose metabolism is one thing and amphotericin is another thing. Both of them have the potential of causing hypokalemia. Means that it can reduce it reduces the level of potassium inside your body, and potassium is a very important ion inside the body. Now, and all patients who get amphotericin are regularly monitored in the hospital. Amphotericin is not something that you can get, you can keep getting it at home, because you will need renal function tests to be repeated every 24 to 48 hours. You need to check that how is your urea, creatinine and potassium levels doing. So we amphotericin in other forms, like you get amphotericin as a crystalline powder which is mixed with sterile water and then mixed with the dextrose. Also, you can use liposomal amphotericin, which is the expensive one. But the good part with liposomal amphotericins is that they can be given in a higher dose to a patient. So you can give up to 5 milligram per kg of liposomal amphotericin, whereas the deoxycholate variant can be given in the range of roughly 1.5 milligrams. So you can give more drug in a day to the patient easily if you're using liposomal amphotericin. But unfortunately, we are finding similar kind of reactions with liposomal amphotericin also. Not just that, our institutional experience has taught us that when we have the different companies fabricating liposomal amphotericin, people are getting reactions, patients are getting reactions from different forms of amphotericin, different brands of amphotericin also. So I hope you enjoyed your coffee with this overview of mucormycosis, and we shall be discussing in our next coffee tutorial more on the management of mucormycosis as well as on the invasive aspergillosis and the laboratory diagnosis of the same as well. So stay connected, keep watching Zanat's Coffee Tutorials in oral and maxillofacial surgery with me. This is Rohit Punga signing off. See you next time. Bye-bye.